Hello, I'm Professor Adam Biener. I'm an assistant professor of economics at Lafayette College, and I want to thank Maxine, Jensen, and the rest of the Family Weekend Committee for inviting me to speak today. Hope you've been enjoying the full program of talks and events, and I want to thank you for taking the time to listen to me today. Now, I'm a health economist, which means I use economic theory and the tools of economic analysis to study healthcare. Health economists have a unique combination of skills that allows them to use data and theory to design effective healthcare policies and determine if healthcare policies successfully achieve their goals. And because their combination of economics, management, and medical knowledge, health economists are routinely employed in both public and private sectors. And before coming to Lafayette, I was a research economist in the U.S. Department of Health and Human Services, where I helped oversee a large federal survey of Americans' healthcare use and spending. While I was there, I conducted research on the medical care cost of obesity, the Affordable Care Act, physician investments in information technology, and racial and ethnic disparities in healthcare and mental health care use. Now that I'm at Lafayette College, I've brought my research here and continuing to expand on it while also preparing a new generation of economists with the skills they need to do empirical analysis in the fields that they are passionate about. What I want to talk to you guys today about is COVID-19 and our healthcare response. At the end of 2019, a cluster of pneumonia cases were identified in Wuhan, China. In early January, these were confirmed to be caused by a novel coronavirus, then known as 2019 nCoV. By January 20th, the first confirmed case appeared in the US, and before the end of the month, there were more cases worldwide than the 2003 SARS outbreak and the 2015 MERS outbreak combined, each of those earlier coronaviruses. Early in March, global cases surpassed 100,000, and currently there have been over 30 million cases worldwide, with almost 1 million deaths. In the US, spread began slow, with nearly a month before the confirmation of domestic transmission. Very soon after, though, transmission rapidly increased through March and April. While some states initiated stay-at-home orders as early as March 19th, others did not shut down until as late as April 7th, when new cases were above 30,000 per day. As of today, there have been nearly 7 million cases in the US, with roughly 200,000 deaths. COVID-19, the disease caused by what is now known as SARS-CoV-2, can be transmitted by individuals with no symptoms through respiratory droplets. Without timely testing, social distancing measures, hand washing, or the use of face masks, individuals can rapidly spread the virus unknowingly. While maybe 1 in 5 individuals with COVID-19 have been asymptomatic or shown no signs or symptoms of being ill, many experienced bad or even severe symptoms of respiratory distress. Roughly 20% of individuals with COVID-19 have been hospitalized. 5% have gone to intensive care units or ICUs, half of which have required ventilation. Presently, 2.9% of individuals who have tested positive for COVID-19 have died. Only recently, we are beginning to understand how worse health outcomes from COVID-19 are associated with advanced age and diseases like obesity, diabetes, and high blood pressure. Our evolving understanding of the disease and the introduction of more effective therapies have helped more individuals have better health outcomes. However, the propensity for unwitting transmission and the vulnerability of many Americans to the disease requires us to be vigilant against further spread until enough individuals are vaccinated as to diminish the rate of transmission. And although many of the problems now caused by COVID-19 seem quite severe and staggering, they are really just the latest iteration of problems that our healthcare system has had from before COVID-19. Entering 2020, the US healthcare system faced many challenges. Despite large gains following the Affordable Care Act, for instance, over 27 million Americans still lack health insurance coverage. 1 in 3 American adults have delayed medical care due to cost, and 1 in 4 delayed treatment for a serious medical condition because of cost. Compared with other countries, healthcare spending as a share of GDP is now double as that in other comparable countries. Additionally, per capita medical spending, what you and I spend on medical care, is double that of other countries here in the United States. In a radio interview, Dr. Richard Besser, President and CEO of the Robert Wood Johnson Foundation and former acting director of the CDC, said, "This pandemic has laid bare a healthcare system that is in tatters. And our existing problems have become only more clear and more urgent as staggering numbers of cases and economic strife due to COVID-19 have strained the healthcare system and disproportionately affected some of the most vulnerable among us. Hospitals have been overwhelmed by high caseloads, shortages of personal protective equipment, and declining revenues from fewer elective procedures, which have pushed many hospitals close to bankruptcy and exposed many healthcare workers to illness and trauma. Persons of color, already having higher incidence with many chronic conditions such as obesity and diabetes, represent a disproportionate share of COVID-19 cases and are more likely to be hospitalized or die from COVID-19 relative to whites. Hispanics and American Indians and Alaska Natives have significantly higher rates of uninsurance, which can deter seeking testing or treatment for COVID-19, probably for fear of receiving high medical bills. And even those with health insurance have faced much confusion about how COVID-19 and testing and treatment will be covered, with some still receiving high unexpected medical bills regardless. Many of these problems can be addressed through health policy. And health economics research has an important role to play in motivating these changes and helping to design effective policies. And here I want to discuss how current research being done by health economists like myself and my colleagues around the country are moving us closer to resolving many of these problems. Before COVID-19, mortality due to most chronic conditions was declining. Yet we've seen a steady increase in the number of Americans with a number of chronic illnesses. In 2018, for instance, over 40% of American adults and 18.5% of children were obese. And individuals with obesity are more likely to have high blood pressure or diabetes, conditions which are associated with having worse COVID-19 health outcomes. Now, work I've done with colleagues has shown that obesity causes significant medical care costs. We found, for instance, that obesity in adults incurred $342 billion in medical spending in 2013 alone. Having done this research, our understanding of the high cost of obesity has increased the willingness of governments and private healthcare payers, like your insurance companies, to invest more in costly, though effective, anti-obesity interventions. Additionally, compared with whites, racial and ethnic minorities in the US, and in particular Blacks, Hispanics, and American Indians and Alaska Natives, have higher rates of asthma, diabetes, and heart disease, among many other chronic and infectious diseases. Decades of social, housing, and economic discrimination have contributed to poorer health for people of color in the US, while simultaneously erecting barriers to accessing needed medical care. Policies to improve access to care and reduce its costs can not only improve health and well-being for all Americans, but can help reduce these disparities. For example, provisions of the Affordable Care Act that took effect in 2014 improved health insurance coverage for all Americans and shrank disparities in insurance coverage. Research done by myself and many other economists found that these insurance expansions helped more people see a doctor, get needed prescriptions. They diagnosed more cancers and improved their overall health, while also reducing the likelihood of bankruptcy or financial instability from high medical bills. And despite these gains, many Americans, and in particular people of color, still lack health insurance or face barriers to getting needed medical care. Before COVID-19, a number of different policies were being proposed to close these insurance gaps and ensure that every American can access medical care at a reasonable price. Health economics research has shown that access improves health, and committing to policy change that is supported by this research will help mitigate the harms that are only being made worse by COVID-19. Now, this lack of insurance, poor access to a doctor, they can prevent people from seeking needed medical care or even getting some preventive care or things like a COVID-19 test. And the reason is often fear of receiving a high medical bill. Before COVID-19, healthcare was significantly more expensive in the US than anywhere else in the world. Without insurance, a person here could be expected to pay the full cost of their care. And even with insurance, a person seeking care in an emergency room or hospital could receive a surprise medical bill for hundreds or maybe even thousands of dollars through no fault of their own, but only because of the way that doctors and insurers decide what your medical care will cost. Uncertainty around the cost of COVID-19 testing and treatment is only the latest iteration of how high cost and complex billing rules can prevent people from getting the care they need. Yet, failure to resolve this problem may have contributed to greater transmission of the virus and insufficient treatment early on in the outbreak, on top of the harm caused by high medical bills. The Families First and CARES Acts, passed in March, helped make testing free for most. Yet, treatment for COVID-19 and its related problems may still be very costly to patients and expose them to high medical bills not covered by insurance. Only a few states have passed consumer protections to prevent these surprise medical bills, and proposed federal legislation is currently stalled in Congress. Reducing the burden and fear of high medical costs is an essential step to improving the functioning of our healthcare system, and health economists, along with policymakers, are working now to better understand this problem to design a solution that will ensure timely access to medical care at a reasonable cost. Because the U.S. healthcare response to COVID-19 has successfully treated many thousands of Americans, developed new therapies, and greatly slowed the transmission of the virus. Yet many failures in our policy response have allowed our structural problems to dictate the effects of COVID-19 on our lives. Health economists and other researchers and policymakers are working now to understand these effects so that we can make needed changes to overcome the pandemic and improve our healthcare system for all Americans. Students at Lafayette College and around the country have the opportunity now to learn the tools needed to help advance effective healthcare policies. And it was a pleasure to speak with you today on this subject, and I hope that you will all stay safe and healthy. Thank you very much, and take care.